Bismillah ar-Rahman ar-Rahim. Today we will talk about antihypertensive management in pregnancy and lactation. First of all, we need to talk about what is the definition and incidence. The global burden of hypertensive disorders of pregnancy affects about 5 to 10% of all pregnancies. Rising trends in the US, the prevalence of hypertensive disorders of pregnancy during delivery hospitalization increased from 13% to 15.9% between 2017 and 2019. Risk factors. Incidence is highest in women aged 35 to 44 by about 18%, and from 45 to 55, the incidence increased by about 31%, and is higher among black women, 20%, and American Indian Alaska Native women, 16.4%. Subtypes break down the prevalence or the incidence in preeclampsia. Eclampsia affects about 3 to 6% of pregnancies. Gestational hypertension affects 5 to 6% of pregnancies, and chronic hypertension complicates approximately 1% of pregnancy. So, levels of blood pressure in hypertensive disorders and types of intervention. There is two types. First of all, is the mild moderate hypertension. It is generally defined by a blood pressure reading of more than 140 over 90 millimeter mercury and measured on two separate occasions. The second is severe hypertension requiring immediate intervention, and its limits is about blood pressure more or equal to about 160 over 110. Before we go into the detailed management, we need to just remind that the types of hypertensive disorders in pregnancy, they are about six types. First of all, the chronic hypertension or pre-existing hypertension. This is exactly the hypertension less than 20 weeks of gestation, or hypertension diagnosed for the first time during pregnancy and not resolved in the postpartum period. Gestational hypertension, that's hypertensions more or after 20 weeks of gestation without proteinuria or other systemic signs. Preeclampsia, new onset hypertension that occurs after 20 weeks of gestation in previously non-hypotensive women with proteinuria or other signs of maternal organ dysfunction. Eclampsia is a severe form of preeclampsia associated with generalized tonic-clonic seizures. HELLP syndrome is a severe form of preeclampsia characterized by hemolysis, elevated liver enzymes, and low platelets. Preeclampsia superimposed on chronic hypertension, the chronic hypertension with accompanied by signs and symptoms of preeclampsia or eclampsia after 20 weeks of gestation. To revise this quickly, the pathophysiology of hypertensive disorders in pregnancy, there is a dedicated risk factors like previous pregnancy with preeclampsia, multifetal gestation, renal disease, chronic hypertension, type 1 and 2, diabetes mellitus, and autoimmune disease. There is always genetic predisposition and maternal environmental factors or immune-related inflammatory factors. All of these factors are affecting uterine endothelial and vascular remodeling that leading to decrease in the spiral blood flow, which affecting the uteroplacental ischemia and hypoxia. This directly affecting fetal growth and restriction or death, and in the mother activating RAS activation and inflammation, it changes in angiogenic factors and platelet aggregation. All of that are affecting systemic maternal organ dysfunction, causing hypertension on the vascular system, and the cardiovascular, renal, pulmonary, brain, hepatic, and hematological, and producing a phenotype like preeclampsia, eclampsia, and HELLP syndrome. So, when to intervene by pharmacological? Thresholds for initiating antihypertensive medications and blood pressure targets. According to the American College of Oncology of Obstetrician and Gynecologists in 2022, they define that if the blood pressure is more or equal to 140 over 90, this mandates anti-pharmacological intervention. Also, this coops with the 2024 ESC and the ESH guidelines that defining that blood pressure more or equal to 140 over 90, mandating pharmacological intervention. So this is a rapid algorithm showing the situations that may be presented by a hypertension in pregnancy. If a chronic hypertension or mild or moderate or a severe acute severe hypertension. To know exactly the limits, the chronic hypertension more or equal to 140 over 90, this is preferred medications, labetalol, nifedipine, and methyl-dopa. And as a prophylaxis for preeclampsia, we give aspirin, 100 to 150 milligram per deciliter. If the patient presenting with acute severe hypertension, blood pressure more or equal 160 over 110, we need to this patient needs to be admitted into the hospital, and there is an IV labetalol hydralazine, and there's some drugs to be avoided like ACE-ARBs, atenolol, and spironolactone. And during the surgeries, prophylaxis in case of eclampsia, magnesium sulfate is mandated, and the definite delivery we need to be optimized by the gynecologist. The postpartum drugs preferred during breastfeedings like nifedipine, labetalol, and metoprolol, captopril, and enalapril. The antepartum management key points, according to the American College of Obstetrician and Gynecology, recommends close monitoring, blood pressure management, and time delivery for hypertensive disorders of pregnancy, with aspirin 81 milligram per day advised for high-risk patients starting between 12 to 28 weeks, ideally before 16 weeks. Pharmacological treatment is initiated for persistent systolic more than or equal to 140 or 160, and the diastole more than 90 to 110 millimeter mercury, with goals of 122 over 80 millimeter mercury. Medications first-line agents including labetalol, nifedipine extended release, and methyl-dopa. Delivery timing, gestational hypertension, preeclampsia without severe features. Delivery is recommended at 37 plus minus 1 weeks. The preeclampsia with severe features, delivery is recommended at 34 plus minus weeks, 1 week, or earlier if maternal fetal condition deteriorates. Final education, patients should be educated on severe features to report, including headache, vision changes, and abdominal pain. The recommended antihypertensive medications commonly used during pregnancy and lactation. The first one is the first-line oral agents, including the long-acting nifedipine, labetalol, and methyl-dopa. Second-line oral agents, hydralazine, clonidine, and the clonidine is not indicated in preeclampsia. The other lines, like possible oral agents with limited evidence, like amlodipine, prazosin, doxazosin, and beta blockers, other than atenolol and thiazide diuretics, with caution taken that beta blockers are not recommended in early pregnancy to avoid fetal growth restrictions, and some guidelines recommend against diuretics. Diuretics are not recommended for preeclampsia. Contraindicated agents, as we all know, ACE and ARB is strictly contraindicated due to the risk of fetal renal damage and fetal death. Antepartum management of severe hypertension, definition and setting. Severe range blood pressure more than 160 and over 110 requires urgent in-hospital care. The acute antihypertensive therapies, including first-line agents, including IV labetalol, IV hydralazine, or oral nifedipine, immediate release, to lower blood pressure promptly and targeting that systolic blood pressure lower than 85 millimeter mercury. Surgical prophylaxis, including magnesium sulfate, is recommended for preventing eclampsia and severe preeclampsia. And the timing of delivery more than 34 delivery is recommended after stabilization. Lower than 34 weeks of gestation, expectant management may be considered at tertiary center if stable, but immediate delivery is necessary if there is uncontrollable hypertension, eclampsia, pulmonary edema, and placental abruption or fetal distress. Fetal and maternal monitoring, continuous fetal monitoring, serial laboratory evaluation, platelet, liver enzyme, and creatinine, and the close surveillance for worsening symptoms. Prevention for high-risk patients, low-dose aspirin is recommended starting between 12 and 28 weeks of gestation. Postpartum follow-up care schedules. Initial assessment within about 3 to 10 days of discharge, having their blood pressure checked either in person via telehealth or through remote monitoring. Midterm review, a 2-week follow-up is recommended, particularly if antihypertensive medications have been adjusted. Comprehensive postpartum visits, 6 to 8 weeks, maximum 12 weeks. Assessment is essential to ensure blood pressure has normalized, proteinuria has resolved, and to address long-term cardiovascular risk. 3 months follow-up, a 3 months check is advised for those with persistent hypertension or proteinuria to evaluate renal and cardiovascular function. Postpartum management of hypertensive disorders. American College of Obstetricians and Gynecologists recommends close monitoring postpartum hypertension with blood pressure targets typically lower than 150 over 100, and in some cases lower than 140 over 90. Key management includes urgent treatment for severe hypertension more than 160 over 110 within about 30 to 60 minutes using labetalol, nifedipine, or hydralazine, and the careful monitoring for postpartum eclampsia, which often peak 5 to 7 days post-delivery. Key aspects of postpartum management: target blood pressure aim for lower than, depending on specific guidelines and patient history. Severe hypertension requires immediate treatment to prevent stroke with agents including labetalol, nifedipine, or hydralazine. Medication selection: calcium channel blockers, nifedipine, amlodipine are commonly used and safe for breastfeeding. Monitoring and follow-up: blood pressure often peak about 5 to 7 days post-delivery. Patients with hypertensive disorder should have a blood pressure check within about 7 to 10 days of delivery or earlier if symptomatic. Prophylaxis by magnesium sulfate is recommended for severe hypertension. Long-term care counseling on increased long-term cardiovascular risk is very crucial. Outpatient management of hypertensive disorders, antenatal and postnatal or postpartum. Outpatient management is suitable for gestational hypertension or preeclampsia without severe features. Monitoring regular outpatients, day hospital or home monitoring is required, typically 1 to 2 times weekly. Components: weekly maternal labs, platelet count, serum creatinine, liver tests, and for antepartum fetal ultrasound Doppler every 2 weeks. Safety measures: patients must be educated or on symptoms requiring immediate triage like severe headache, visual disturbances, and epigastric pain. Medication management: antihypertensive should be adjusted to keep blood pressure lower than 140 over 90 millimeter mercury. There is a postpartum hypertension clinics, models of clinics, multidisciplinary transition clinics between obstetrician and the gynecologists and internal medicine and family medicine and the cardiologists have proven effective in managing high-risk patients. They exactly focusing on remote monitoring, providing Bluetooth-enabled blood pressure cuffs for home monitoring significantly improves adherence to follow-up up to about 94% in some programs. Medication titrations: these clinics allow for timely medication adjustments and reductions, example switching from methyl-dopa, which may increasing depression risk. Readmission prevention: early and proactive intervention in these clinics have reduced readmission rates. Long-term cardiovascular follow-up: hypertensive disorders of pregnancy as a significant risk factor for future cardiovascular disease, including chronic hypertension and heart failure. So there is an annual review, lifelong annual medical reviews to are advised to monitor blood pressure and promote healthy lifestyle habits, exercise, diet, and weight management. Cardiovascular referral: patients with severe persistent hypertensive disorders of pregnancy should be referred for long-term specialized cardiac follow-up. And finally, future pregnancies, preconception counseling is recommended to discuss low-dose aspirins and other preventive strategies. And thank you.